Thanks, Todd. Well, as you can see, I think from the two previous speakers, certainly the technical aspects of telementoring and the teaching platform for which to do it are there and very doable. And I think something that would benefit, most of us would argue would benefit any surgeon who is trying to take on a new technique or learn a new procedure. And this is ultimately the goal. Now, this is me telementoring a case in Paris of a thoracoscopic thymectomy. Surgeon I had a relationship with had actually trained in a previous lab. She'd not seen me do this procedure, nor had I been in her operating room, so we sort of skipped a couple steps, but I knew she had the technical ability, but I think I was enabled her to do this. I will tell you that the ability to do this case, partly because of the help of Stortz in this particular case, was much easier than doing this, which was having me beam into Akron and help Todd, although Todd's team, he's very fortunate that he has a great team that works with him, and this just shows you we're using a different platform, not quite as robust, but we were able to beam the image in both on my laptop and on an iPad. But sometimes the logistical challenges are incredible. I'll talk a little bit more of that. So as already been mentioned, from a technical standpoint, what platform do you use? And as Todd showed you, we've done anything from Skype to Visitor One. So from a very basic minimal platform where you can just communicate and get adequate visualization to a very robust platform that allows you to communicate face-to-face, allows you to telestrate, allows you to see both the outside view and the inside view, I think, and then also active telestration. And so it really depends on what you're trying to do, but the platforms are definitely there. I think the biggest issue to which platform you use is going to be cost, and for your particular situation or for your hospital, how you choose to do that. Medical legal is a huge deal. And the question is the mentor liable? Is he part of the surgical team? Does he need to get consent? Is the patient need to be informed? Does he need to have hospital privileges? Does he need malpractice insurance? And we'll talk about all these issues. And then the other parts we'll go through one by one. So technical, what platform? Is it integrated into the OR, or is it totally separate solution? Initially, I thought it needed to be integrated into the OR, but now I think some of the platforms are coming out would allow it to be totally separate and a plug and play in any OR. Part of the problem is hospital IT and HIPAA compliance, and then firewall. So I mentioned that the case we did with France was relatively easy. I have Visitor One in my hospital. I have a laptop. They just brought one in. I don't really know what they went through to get it to work in the OR in France, but from my standpoint, it was pretty easy. I also, because I work at Columbia University in New York once a month and am on site and have an academic appointment there, we've set up a communication of 2 Visitor Ones between the Children's Hospital of New York, or CHONY, and my hospital, Rocky Mountain Hospital for Surgery, and it took us over a year to get through the IT hurdles in the firewall. So it's very institution dependent on what you're able to accomplish. And then there needs to be compatibility, and I think as Dr. Duncan has said, and as our committee has pushed to try and get all these systems to be compatible, and no matter what you use, but I think that's going to be a very difficult thing. And then the quality of the connection, and that can be very variability, and it can interrupt your communication. Even yesterday when we were doing the telementoring just with MGH for the sleeve resection, we had some problems with audio that came through, and that can happen. And so ideally in a critical case, we always say that the mentee surgeon needs to be able to do the procedure on their own, at least safely. Maybe not the way we would do it, maybe not endoscopically, but they need to be able to complete the surgery safely. But there are still times when these procedures get interrupted, and we need to eliminate that if possible. From a medical legal standpoint, again, is the mentor liable? Is he part of the surgical team? Does he need to get a consent? How is the patient informed? Does he need hospital privileges? Does he need malpractice insurance? Does he need a state license? And when we started this, we were kind of hoping that we could get around all this and that we could say no. Part of the reason I was able to do what I do with New York is because I'm licensed both in Colorado and New York, and I have appointments at both places. When I helped Todd out, I had previously been out there and operated with him, and we had gotten me a temporary license, and so that may have helped some. But the answer to all of this is yes. After you sit and talk with some of the regulatory people and with the insurance carriers, there's no way around this. All of these things are positive unless we change the regulation, and that's going to be, unfortunately, something that we're going to need to get from the federal government, and we need to figure out how to lobby for that and do it. This is just to show you, this is something that the American Telemedicine Association put together, and I know it's an incredibly busy slide, and I didn't actually want you to be able to read it, but I have 10 pages of this, and it breaks down the different regulations that each state has for just telemedicine. And it's incredibly variable, from some states being willing to say, yeah, you know, this is kind of Good Samaritan, you don't need anything, to others, you need to be licensed and accredited in every hospital that you go to and have privileges. So let alone going across state lines, which is a lot of what telementoring will be, I think. And so there's a huge battle here and a lot of work to be done, and I think this is our biggest blockade. There are other things that I've learned through going through this, and that's scheduling. So trying to schedule the mentor, so the available of the mentor and the mentee. So when you do it, you know, if you're doing it in the same time zone, that gets a little bit easier. A lot of times when I've done it, if I've been helping Todd or someone on the East Coast, they're 2 hours ahead of me. I come in at 5:30 in the morning to do a 7:30 case, so that for them, so that then I can start my workload at the right time. But as in the case from France, if your case gets delayed, their case gets delayed, suddenly it interrupts my workflow. And that's extremely difficult. So I ended up mentoring that case in between my cases. I did a case waiting for when they were ready to go, and then I put one of my cases on hold to be able to do that. And we had similar issues in Akron with delays and things that are out of your control. So it's really tough to schedule these. It has to be a priority in both ORs, both for the mentee and the mentor, to try and make this done. And then there are the unforeseen issues of case delayed, equipment not available, or the connection fails. And then who coordinates all this? You know, who's going to take charge and do this? When you do it on a personal level like we have, we kind of work together, but there really needs to be someone who looks over this. The business model, I also think, is a large logistical problem. Who pays? Right now, this is actually being driven by the mentors, people who have a vision like Brian and see the benefit to this, and I think educators. But this really needs to be driven by the consumer, and I'm not quite sure who the consumer is. Is the consumer the surgeon? I think in some ways, yes. You know, maybe, and I think as things go on, but you know, maybe for a surgeon to come join a hospital system, if he knows they have a mentor-mentee program intact, that will be an added benefit to him to come work for that system or that hospital. The hospital, is that our you know, the end payer? You know, what benefit do they get? Well, hopefully better outcomes. So I think we have to prove where the value added is and go there. So the good news is there's rapid adoption of new techniques. It's dramatically shortened the learning curve. There's increased staff and resident confidence in these. The surgeon and the patient benefit, and otherwise unavailable surgical expertise. You may get increased referrals and a competitive edge, and we need to push these points to get that consumer advocacy for doing this. So this is just what our system looks like between Denver and New York. It's kind of bulky, it's expensive. I think it's going to get better. This is kind of the newer version, so you could have my smiling face in your OR on a daily basis. But this is a similar solution, but now rather than have that big robot hanging up, this is a pad that will just come in and clamp onto your monitor, be right there. and plug and play. So this is where we're getting to, and I think this is the technical solution we have. So that logistical challenge will be better. But we still need to create a pool of experts. I think we need a network of integrated operating rooms to prove this. And then there needs to be a central scheduling and consultation for mentoring sessions. And then, we can improve practices, I think, with this. And I'd show you this just because this is a friend of mine. He is not a surgeon. He is actually involved in industry. He runs a big plastics plant that's an international company. And this is what they're going to. So they're going to a command center with experts sitting in the command center. They're top engineers. And then at all of their sites, they'll have people with VR so that when they're fixing instrumentation, when they're problem solving, they'll be tuned in to a group of mentors. And I think, industry's certainly looking at this, and I don't think this concept is much different than what we're trying to do, and I think we can use it as a model and to help sort of sell it. So I think there's a lot of synergy there that we should look at. Anyway, thank you very much for your attention.